Well, thank you very much. What a great series of talks here. And of course, one of the things that we all struggle with is this combinations of multivalvular disease in case of aortic stenosis and mitral regurgitation. My conflicts have not changed in the last hour. I'm going to start this with actually, there's no better person to quote about all of this is Bob Bono. And Bob, when he talked about mitral regurgitation, what's controversial or unsettled in the guidelines, said everything is unsettled and controversial. So I think I can sit down and we'll have gained 15 minutes in our day. I can't do that, I guess, so we'll have to talk about this. I think it is important, and we've spent a whole session describing the fact that MR is not a single entity. And so as we're thinking about this, I want to recall our attention to the fact that when you say ASMR, it's not ASMR, it's AS in either a degenerative valve or flail leaflets or functional or something. And so as we look at the data, we do have to think about that combination. We have some information, but not a lot of information about that. So let's look at what the guidelines tell us, and I'll highlight this simply to remind us that what we say in the United States is AS and severe MR with symptoms, LV dysfunction or pulmonary hypertension, should undergo combined AVR and mitral valve replacement. However, the asterisk is, in patients with severe AS and lesser degrees of MR, the severity of MR may improve greatly after isolated AVR. We heard about the back room with people smoking cigars and drinking scotch and coming up with these C-level of decisions, and I think this may fit that smoky back room, because when we look at the data about all of this, in fact, it's a little cloudy. Now, our European colleagues are just as good about this. What they say is that when MR is associated with severe AS, its severity may be overestimated in the presence of high ventricular pressures, and careful quantitation is required. Had a lot of discussion about that. And as long as there are no morphologic leaflet abnormalities, goes through the list, and you can see the long list: flail or prolapse, post-traumatic changes, signs of infective endocarditis, mitral annular dilatation, ... leave it alone. So they're being much more conservative about the treatment of that. So what do we know about that? We know that clinically significant MR is often found in conjunction with severe AS. We'll talk about that. Coexistent mild or moderate MR may increase both early and late following, may increase the mortality following AVR. And the double valve replacement, even in today as we are readjusting the experience, is that it is associated, at least earlier on from the STS, with a higher operative risk and a postoperative mortality that at least remotely was in the 10 to 12% range. And so we're getting mixed messages here. On the one side, we're saying don't enter, and the other is saying entrance only. Now, this is San Antonio signs. I'm sure you have nothing like that here in Houston. But when we look at this, in fact, if you look at comparative 30-day mortality in the odds ratio, you'll see that people that have less MR do better on the top, and 5-year survival on the bottom, a hazard ratio, so that people with moderate to severe MR do worse. Now, this is a composite from Harling. I'm going to summarize what it tells us, and that is, from this trial, they found that despite reverse remodeling, concomitant moderate to severe MR adversely affected both early and late mortality following AVR, and as such, concomitant mitral intervention should be considered in the presence of that, independent of the etiology. Schubert looked at their outcomes in the natural history of MR after AVR and showed that if you had preoperative mild MR on the top of this and compared it to those individuals that had moderate or greater MR, that if you followed those patients out to 5 years, that there was a better survival in those that had mild MR. That's not shocking, but it is consistent with what we understand. What was interesting from this is that they did look at those whose MR improved or those who did not have improvement in MR, and there the separation was much greater, and so if you had improvement, it was a good sign. The problem is we don't really have any data that tells us who's going to improve, and that, as I looked at the literature, wasn't very robust. I'll come back to some of the features of people that were likely to not do as well, however, in a second. We do know that in TAVR we see much of the same thing, and here's a composite of the different registries that show a variation in the prevalence of moderate to severe MR in roughly 8 to 20 of patients, and it varies broadly based upon who it was. If you look at the randomized trials or the larger trials, however, it's about 1 in 5 patients. So post-surgery, the predictors of MR progression after isolated AVR included a depressed ejection fraction, atrial fibrillation, larger left atrial size, and the etiology, degenerative as opposed to functional MR. And so those should be clinical features that we take into account as we're trying to identify those patients at risk. We've seen this slide before, but what it shows is in the TAVR group in particular that the MR itself does drive late outcomes in those patients. The etiology across these variety of series of MR is interesting in that it is not what we might have thought, that is functional, but in fact a large percentage are degenerative or so-called organic across the entire series, and you can see here a significant number, and it's about, in the composite overall of that, about 60% as opposed to 30%, which is interesting that in fact there is so much in these TAVR trials at least of a degenerative valve as opposed to a functional valve that's involved. We do know that this clinically impacts TAVR as well. If you look at this risk progression from a single series, 350 patients followed for 5 years, but I think is a good trial. And they had very good assessment of these patients. And you can see, not surprisingly, diabetes, COPD, chronic renal failure were included as risks for poor outcome, but unappreciated, I think, has been the driver of moderate or severe MR and was nearly the same and greater, in fact, than diabetes. So it's, again, from this Italian group tells us about how large the problem is in this group. During this last year, Nimbala summarized 30-day and 1-year mortality in a meta-analysis of 8 studies. You can see here that as a driver in almost all of these, significant increases in overall mortality with a risk factor composite that's nearly 2.5-fold across the group. We often say these patients are going to get better, and that's what we said with surgery, but the data, at least from this meta-analysis, showed that although the MR got a little bit better, shown in the left-hand panel of this, it didn't get a lot better. And so they still had about the same number. 1 in 5 had no MR. Moderate MR got a little worse. Severe MR got a little bit better, but we're sort of left in that group. And if you looked at severe MR at baseline, about 2/3 improved in red, and about 40% stayed the same. If you had moderate MR as opposed to severe, it's about 50-50, and a significant minority got better as well. There are some suggestions that there may be some differences, and admittedly these are data collected over progression and development of the devices that we have. But it is interesting that if one looked at self-expanding valves compared to balloon expandable valves, we saw some interesting trends. So if you looked at the pooled data for all patients, improved between those groups, a little higher number in terms of that, but if you looked at the more than moderate MR in particular, you had a little better improvement in balloon expandable versus the self-expanding valve. The differences for that are entirely speculative, but people have talked about the fact that the frame in the self-expanding valve might physically interfere with the anterior leaflet of the mitral apparatus. That's been speculated. Core valve system may, because of perivalvular leak, may maintain more of a load on the ventricle and contribute to less improvement in the MR, that it may be associated with bundle branch block, and because of the pacemaker may contribute to ventricular asynchrony, and that may be secondary. And I think all of those are things that one can speculate upon, but are really unproven in any fashion at all. So the impact of MR and mortality was not different between the self-expanding and balloon expandable valves in this meta-regression, and this really is the largest database that we have to think about today. Moderate to severe MR improved in about half of the patients at 180 days, and the degree of improvement was in this group higher in the balloon expandable versus self-expandable. But across the composite, it really is how the patient felt, and there was no signal that they had to have more procedures. And interestingly enough, when we look at TAVR, what do we see about those things that predict improvement? those that had lower ejection fraction. Now here, lower ejection fraction was actually simply less than 50%. So that's a pretty high bar in terms of if anybody under 50%, because that's the group of patients that we're looking at for the low flow state. Etiology of MR, secondary versus primary, were more likely to improve secondary versus primary. So slightly different than what we saw in the surgical valve, absence of MAC with restriction, absence of atrial fibrillation, and absence of pulmonary hypertension. So those patients that didn't have evidence that suggested the mitral regurgitation was the driver as a primary event for their clinical presentation. And there's some data that suggests that the deep implantation of the core valve may be associated with that. And as I said, I think that's speculative more than proven. If we look at the question of combinations of valvular lesions, and the AOR was brought up before, what evidence do we have about that? A group in Poland did ask that question. You can see here sort of non-significant AR with significant AR, significant AR, non-significant AR, no differences. The far right panel I want to bring up and highlight, because what it shows us is that if you have both AR, or a significant AR and significant MR, that's a group of patients that we need to pay a higher degree of attention to. So this is really a group that we need to focus on in terms of paying attention to both of those. Fortunately, with the new valves, I think we're seeing a lot less AR, whether it's the Resolute or the S3, and so these kinds of cases I think are going to be less significant and less frequent. So what can we conclude? Well, there's not a lot of data out there. Significant MR is often found, roughly half the patients undergoing SAVR and TAVR. The real impact on midterm outcomes and the correct management still remains controversial. There are no randomized studies available to tell us how to approach these patients. Transcatheter valve therapy for combined severe AS and significant MR is attractive and should be prospectively evaluated, although how we implement that I think is a little difficult to talk about in today's reimbursement world. A TAVR first strategy in high-risk patients. It's interesting, TAVR and MR therapy during the same setting has been reported. Possibility of spontaneous reduction in MR after isolated treatment of AS, potential to avoid unnecessary additional procedures on the valve if you're using it as a staged procedure. Increased risk associated with mitral valve surgery performed for MR following isolated aortic valve surgery. Prior TAVR does not seem to result in the same increase. And it's probably worth a prospective evaluation. So, thank you for your attention.